However, we don't want you to just think of Achilles tendon. We want you to have other options as well, right? So maybe the back of your mind where you're thinking, maybe this is a muscle tendinous problem where it's a little bit more superior or proximal. Maybe it's a little bit lower down where it's at the insertion, and we think of it as Sievers or Haglund's or apophysitis, right? So you think of other things that are still in that same location, right? And that's how we kind of keep ourselves honest. We don't have any of these confirmation biases, and we start Achilles tendinopathy treatment right away. Right? So if we think about prevalence, so again, we're going down tendonitis or tendinopathy, who's most likely to have Achilles problems? Describe the person that's walking in your clinic.
Obese individuals, sports players, overpronators, elderly.
Awesome. Awesome. Those are really good. Yeah. One of the big risk factors is having a high BMI. So yeah, so a BMI over 30 definitely increases your risk of having Achilles tendinopathy. Good. The other one, sports, yeah, being overactive. And it's not necessarily just being active in general. Is there a sudden change in activity? So and that change can be someone who's used to running 3 to 4 miles and decide to go run 10 miles, right? So they're already very active. They run 3 miles a couple times a week, and now they're trying to do more. So that sudden jump in activity, right? I think you said elderly as well. Yep. Okay. Yeah. So maybe different from what we think, that we think it's more common in younger people, but actually the most common age is this like 40 to 59-year-olds. So a little bit older, just because they may go from a very low level of not doing anything. So then when they go try to run a mile or go for a 1-hour hike, they're not used to doing much. So then they get these tendinopathy issues, especially because their tendons probably aren't the youngest and healthiest to begin with. Good. If you had to think of number one activity, what do you think is the number one activity that relates to people getting Achilles tendinopathy issues?
Running.
Running. Yep. Running is the biggest one. Good. Okay. So that's our prevalence data. If we kind of look at it, right?
Dr. LeMoine.
Yes.
Can you mute Megan Lane and then the 513318 number?
Yep, I sure can. Give me one sec, guys. We're just gonna go mute all. Cool. There we go. Nice. Okay. Yeah, so you see it in runners, you see it in soccer players, you see it more in males. Most common age, 40 to 59. Increases with age, increases with activity. Yeah, you guys were right on. So good job. All right. So clinical findings. So that's kind of the person describing coming in. What are some tests that we'd want to do? So they're coming to the clinic. What are some of the things we're going to do to kind of rule in or maybe rule out this Achilles tendinopathy?
Thompson Test.
Okay. So what with the Thompson test, what is that trying to rule in or rule out? What is the Thompson test trying to do?
Rupture.
Rupture, exactly, yeah. So if someone ruptured their Achilles, right? The Thompson test means when you squeeze the calf, if the tendon is attached, when I squeeze the calf, it's going to plantar flex the foot, right? If it's not attached, then when I squeeze, nothing's going to happen to the foot. So a positive test is the foot does not move. And those are things that, right, they should probably be sent to orthopedics to be booted, to be healerized, or to look to see if it's a surgical candidate, right? Good. All right, so how about if we're going to rule in a tendinopathy where it's not torn, right? But we want to say, is this an Achilles problem? Is it a nerve problem? What are some good tests to do?
Palpation.
Yeah, palpation. Right? Anytime we have a tendon issue, whether it's patellar tendon, lat epi, right? Tendons should be able to handle pressure, right? So doing kind of a pain pressure threshold or palpating tells us, is that their pain, yes or no? Good. So that's a good one to do.
Straight leg raise to rule out nerve involvement.
Perfect. Yeah, straight leg raise. Yep. And if we wanted to throw in a bias to that, right, you think about the most common one down there would be like a tibial bias. So what would be our foot position for a tibial nerve bias?
Dorsiflexion, eversion, and then we also have plantar flexion and dorsiflexion, and then we have eversion dorsiflexion.
Good. So the last one, eversion dorsiflexion, right? So because it runs on the medial side of the foot a little bit, you want to evert. And because it goes posterior to the ankle joint, we want to dorsiflex. Both of those motions put it on tension. All right, so let's say we do our straight leg raise, it's negative. All right, so dorsiflexion, eversion is negative, so it's not a nerve issue. We've palpated the tendon. It reproduces their pain. Are there any other tests that can help to rule in Achilles?
Melissa said a Royal London Hospital test.
Okay. Yep. So Royal London, meaning when you palpate and you palpate the tendon, it's pretty painful. You then can move the ankle back and forth in the dorsiflexion, plantar flexion, and you're looking to see if, like, does this fluid move? There's two tests that the guidelines use. One is the ARC test and one is the Royal London. One of them is about when you palpate and then you dorsiflex and you palpate again, it should hurt less, right? And we'll talk about why that is in a second. And then the second one is if you dorsiflex and plantar flex, do you see fluid in the tendon moving, right? And that's kind of, if you can move it and it shows that there's some fluid moving, you're saying, okay, there must be there's an accumulation of fluid in this tendon that would fit with a tendonitis, right? But that being said, most of the people, as I said earlier, really aren't a tendonitis. They're more of a tendinopathy, right? So maybe a tendinosis. So we may not actually see this visible swelling unless they are pretty acute, right? So if we go back to the ARC test where you palpate, it hurts, then you press it down and it hurts less, right? Why do you guys think it hurts less when you put it on tension, when you dorsiflex the foot?
Stabilize, providing stability.
Okay. I'll give people a second. Another second. So again, we palpate the tendon when it's in like an open pack. When it's loose, it hurts. We then put it on a stretch. We put it on a stretch and we palpate it again and it hurts less.
Reduce pain.
It does reduce pain. Right? That would make it a positive test for Achilles tendinopathy. But why do you think it hurts less when you put it on a stretch?
Tendon has moved.
Okay. Yep. Tendon has moved. Right. So the whole idea of it is, right, tendons have a lot of nociceptors and mechanoreceptors, right? So when the muscle is shortened and relaxed and the tendon's relaxed, none of your mechanoreceptors are firing. So when you squeeze it, your nociceptors, which carry signals to tell you if you're like that help related to pain, are able to be fired very quickly. When you put something on a stretch, you've now activated all these mechanoreceptors, right? So the mechanoreceptors are really just stealing from the nociceptors. So now when you palpate it, the nociceptors can't send nearly as much signals up the chain because you put it on this mechanical load. So that would be like if you go really down deep to the biology of these receptors on why it actually hurts less. And that's often why things hurt less when we stretch them, right? Think of a lot of diagnoses that are related to tendons and muscles, and that it actually, you get pain relief when you stretch because you're really just sometimes minimizing how much nociceptive information is sent up because mechanoreceptors are overpowering them. And that's kind of the same reason why we rub things, right? You fall, you hit your head or whatever, and then what do? We rub it, and it kind of feels better because you're just activating other receptors, right? So that's maybe a little farther down in this. We start talking about like persistent and central pain. But that would be why with that test. All right, so we palpated it, we brought on pain. Again, when we palpate it, we want to identify, is it at the mid-substance where it's most painful? Is it higher up at the muscular tendinous junction? Or is it a little bit further down at the insertion, right? So we want to be clear about when we palpate it, where exactly in this tendon is it painful, right? Where do you think is it most commonly painful? Right? If we think about We have proximal, mid, and distal. What is the most common type of Achilles problem? You think it's proximal, mid, or distal?
We have 3 distals, 1 proximal, 4 distals.
Okay.
5 distals.
Okay.
6
So,
distals.
sorry guys, I'm gonna burst your bubble here, but the most common is mid substance. So in the midsection, so about 2 to 6 centimeters up from insertion, they call that mid substance, right? That is the most common. That's about 55 to 65% of all Achilles pain problems that are reported, right? Distal would be second most common is distal at the insertional, and then last is musculotendinous junction, right? And again, I want to stress the importance of identifying that because you treat those very, 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 very differently, right? And we'll talk about treatment when we get there. So besides doing these tests to rule out a Achilles tear, someone threw out Thompson Test, fantastic. We have these tests that rule in, is the tendon the source of pain, palpation, does the tendon move, does the fluid move, etc. What are some other things we'd want to do in our objective exam for this patient? Because really, we're not going to just have them lay on the table and palpate it and say, oh, you're good. What other tests and exams would you want to look at?
Range of motion, flexibility, strength.
Okay, so strength of what? Range of motion of what? Flexibility of what?
We have some functional tests, the lunge and the squat.
Perfect. Awesome. Those are great. Yeah, some of the functional tests, right? Because most of the time, as we said, this pain starts from overdoing something, whether it's walking, running, hiking, some type of functional stuff. So looking at how their ankle and their tendon moves and is used in function. And so if we watch somebody squat, we watch somebody do a lunge, it tells us a lot about their foot, their ankle, how it moves. So that's fantastic.
We have strength, dorsiflexion, plantar flexion, and range of motion of that as well.
Okay, good. Dorsiflexion, yep. So we want to look at ankle joint mobility, right? Mobility, just like obesity is a risk factor for Achilles problems, a lack of ankle mobility is a risk factor for Achilles problems as well. All right, good. All right, good. So if I go to key findings, right? So we have our ankle mobility assessment, right? So we do want to look at active range, overpressures, and we want to look at that joint mobility, right? So looking at talocrural mobility, right? The one that is a risk factor is a lack of dorsiflexion, right? Not necessarily lack of plantar flexion, but lack of dorsiflexion, that's a risk factor. So that would be us looking at ankle mobility assessment, right? If we looked at our tendon assessment, right? So yes, you guys talked about tendon palpation, arc sign, Royal London test. What about looking at our gastroc strength, right? So just looking at plantar flexion strength, right? So either holding onto their hands or putting them on a wall. When we were filming this, we didn't really have a wall nearby in the middle of the room. So I'd much rather put someone on a wall so that way you could see them, right? And we're looking at that. So if someone with Achilles tendinopathy, you have them do a heel raise, what do you guys think is going to happen?
Pain.
Good. Yeah. If you're using that muscle and that tendon, you're expecting it to kind of hurt, right? So part of this test is just a test for, does this hurt provocatively? It helps me with my diagnosis. Because if someone does a heel raise and it doesn't hurt, all of a sudden Achilles tendinopathy tends to go down a little bit, right? What else are we looking for when they do their heel raise test?
Proper mechanics.
Okay, good. There's 2 proper mechanics that are related to a heel raise. What do you guys think? Actually, we'll call it 3. What are some of these proper mechanics? When someone goes up onto their toes, we want to, what are the common compensations that can occur?
Trendelenburg, inversion, supination, ankle inversion.
Good. Yeah, so you go up on your toes, you definitely want to see the calcaneus invert and supinate, right? You want to see it go in, right? Your gastroc muscle is a big rear foot supinator, so that's awesome. Good job. So you do want to see that. If someone goes up on their toes and you don't see inversion of the calcaneus, right, then that's a problem. A problem of maybe there's a mobility problem of the calcaneus, or they're not strong enough to get high enough on their calf. So we have to decide that. Good. That's one. I think I heard Trendelenburg gait or Trendelenburg. Yeah. So maybe when they go up on their toes, you see compensation up above, whether the knee tries to flex, right? If the knee flexes, they want to use their soleus instead of their gastroc, or the hip may drop, meaning they don't have good pelvic stability from the glute med. Okay? There's one other thing we're looking for. When I go up on my toes,
We have eccentric control coming down.
okay, so yeah, eccentric control wasn't the actually, that would be a good form to show strength, but as far as like mechanics, where should we weight bear at? When I go up on my toes, where should majority of my weight be?
Forefoot, ball of foot, midfoot.
Good. So yes, it should definitely be on the forefoot, but it should be on that medial side. So the ball of your foot, they call it your first MTP, right? They're your first ray. 70% should be there, and the other 30 should be spread out across your other four. So your pinky shouldn't be in the air, but majority should be on your first ray. And that's because it's really activating that peroneus longus that wraps under your foot and attaches to the first ray, and it's pulling it down into plantar flexion. Right, so you have from the back side, your calcaneus is inverted, and from the front side, your first ray is being plantar flexed by your peroneal. So you're getting all these big arch muscles to help support your foot as you go into plantar flexion. All right, and remember, plantar flexion is considered a rigid foot with supination, right? You think about when I supinate, you're plantar flexing, and that's your push-off phase of gait, right? When we push off, we want a pretty stable foot, right? The opposite of pronation. So good job. So really we think of a heel raise test as, hey, does it hurt? Yes or no? And then when they do it, what's their form look like, right? Are they able to keep their knees straight? Are they able to go up pretty high? Are they able to get inversion of the calcaneus? Are they able to keep the big toe down? Right? All those things kind of go into our mind. So mechanics, pain, mechanics. There's one more thing we're looking for when we do a heel raise test. What do you guys think?
Balance. Proprioception.
No, we want to take balance and proprioception away. We want them to use support. Otherwise it can decrease.
Quality of reps, weakness.
Yeah, exactly. It's technically a strength test, right? So we could do this with someone with knee pain, and we're going to be looking for reps, right? We may not expect it to hurt because they don't have Achilles problem, but we're looking for reps. So same thing with Achilles. Even though it hurts, I'm going to have them go through it and see how many reps they can do, unless there's something in their subjective that told me their irritability is pretty high. So if they're coming in saying, you know, this has been bothering me for 4 days, and when I walk on it, I tried to walk half a block, and it was painful for the rest of the day. Okay, that's high irritability. Maybe I'll have them do one. It hurts, I stop. But if they say, hey, I've had this for a couple months, I've been living with it, then I'm going to have them do a rep. If it's a 3 or 4 out of 10, I'm going to have them keep going as many as they can, because it's probably just going to stay at that 3 or 4 out of 10. And I want to see really what is their strength. Okay. And that's going to be one of the key things about Achilles problems, is that we really don't need to be scared of the pain levels if it's out of the inflammatory stage, right? So good. So far we have our palpation skills, our ankle mobility skills. We have some functional tests, squat, lunge, looking at, do they have dorsiflexion? What's the tendon do? And then we want to look at calf strength, right? Gastric strength. Good job. So if we go to associated impairments, right? So those would be our key findings, right? From that point on, I should be able to say, you know what? I'm pretty confident this is an Achilles problem. I should be pretty confident that I could tell that this is a mid-substance problem versus a muscular tendinous junction problem versus a calcaneal apophysitis problem, right? Or a retrocalcaneal bursitis, something more distal. I should be able to know that by now. I should have a good asterisk sign. How many heel raises can they do? How much pain do they have with squat? How much pain do they have with walking or running? I can look at running mechanics, walking mechanics, all those functional stuff. Are there any other impairments that we'd want to look at? So remember, impairments don't have to be painful. It's purely just something we treat. What would be another impairment that you might end up treating down the line that you want to look at?
Blood clot.
Okay. So that would maybe not an impairment as much as a red flag differential, but that's definitely one to keep in the back of our mind. If someone's having calf pain, especially if they're older, maybe they had they're post-surgical, they're immobilized, then right, a DVT or a blood clot should be on our radar. I'd say that.
Proximal hip strength and mid toe extension.
Good. Okay. Good. So proximal hip strength. Yes, there's a study that came out that looked at, and again, it's just a correlation study, but people that developed Achilles tendinopathies tended to have weaker hip glute medius and glute max on that same side. So biomechanically, they were trying to make the correlation between when you walk and you have a hip drop, or when your femur internally rotates and adducts, it can change the mechanics at the foot, leading to more foot issues like Achilles tendinopathy. So yeah, so we may definitely be looking at hip strength. Again, do we expect that to hurt the ankle when I test someone's hip strength? No, right? So it's not really a key test. It's more of an impairment test, but something to keep in mind. What was the other one, Cam?
Big toe extension.
Big toe extension, yes. How can you guys correlate if someone lacks big toe extension mobility? How can that correlate to maybe being a risk factor or an impairment with Achilles tendinopathy? It's kind of a tough question, but can you make the connection between lack of big toe extension and Achilles stresses?
Neurological compression or improper mechanics with walking.
Okay.
Gait pattern.
Okay. Can you guys take that a step farther?
Early heel rise.
Okay, good. So the improper mechanics with walking, that's true, but what would they be? And the idea would be if I don't have big toe extension, and I'm not getting to my 60, 70 degrees in function, it means then I'm going to lose my terminal stance phase of gait, which means my heel may come up a little bit earlier. I may be loading my calf a little bit more, meaning it could stress the Achilles more. The other thing is we need big toe extension to get our windlass mechanism to be activated, right? Our windlass mechanism doesn't get activated until you get big toe extension, and then that tightens up your midfoot for you. So if I have a not so tight midfoot, right, I'm not able to get my windlass mechanism to be helpful. It means I'm going to rely a lot more on a muscular tension to try to get that supination and that midfoot control. And as we talked about earlier, what's one of our big supinators from the rear? Our Achilles. So if my midfoot doesn't lock up well from my windlass, which is big toe extension, then my rear foot's going to try to work harder to do that for me. Right? So good. And again, that's a little bit further down the line as far as maybe not the lowest hanging fruit, maybe not the number one treatment you do. There's other things that will probably, but again, if you test the other things and they're normal, that may be what you work on. I had a runner probably 2 years ago, an older, he was a master sprinter. And so I think he was like 65, 66, does a lot of running, tracks is pretty impressive. But he had a bunionectomy like 9 months before, and he rehabbed his bunionectomy and his goal was to get back to running, which majority of the time people don't, but that's kind of what he did in his retirement was he ran. And he started to develop some pretty gnarly Achilles tendonitis, some IT band, like all these other issues up the chain. Granted, he had other impairments, but the only big thing that changed in his life was he had this bunionectomy, right? And he was running before that, bunionectomy. Now afterwards, his big toe didn't bother him, but it was all these other things up the chain that started to bother him. And what we ended up going back to was really cranking on his big toe and being like, hey, if you're going to be running, you got to get as much out of this as you can to save the other joints going up from changing as much. So good job with that. So we have early heel raise, big toe extension, hip strength, someone said. So it's good. So all those things are great impairments, right? So we talked about looking at dorsiflexion range, right, as a risk factor. Subtalar mobility. Remember we talked about the calcaneus needs to invert when we go into our heel raise. If it doesn't invert, is it a mobility problem, right? Midfoot mobility, right? Are they able to get to supination, right? We can look at arch strength, right? Just like the windlass mechanism, right, helps support our midfoot. If we don't have the muscles, which would be, what would be the two big muscles that would help support your arch? There's a lot of them, but there's two big external ones. What would be the two big arch muscles that help control your midfoot?
Tibialis anterior and posterior.
Okay. So I'll give you one of those. Tibialis posterior is a big one. That's the medial side. Yes, your tibialis anterior does help do some inversion. But what would be the one on the lateral side? What would be a good lateral ankle muscle that helps?
Peroneus longus.
You got it. So yeah, so post tib on the medial side, peroneus longus on the lateral side, wrapping around. Good. Right, and those would kind of be our two big tests for it. Okay, good. So we've talked about key findings. We've talked about associated impairment. Differential, we talked about pretty early on, right? And I like how somebody threw out a couple of red flags. So maybe it's a tear like a Thompson test. Maybe there's a blood clot. Someone threw out nerve. All right, so I think if it's coming from up above, let's say you do all this foot stuff and it's negative, maybe it is a lumbar problem and we got to check nerve stuff. So great. So you guys pretty much already covered all of that. So the idea would be movement faults. What movement faults when you watch someone squat or you watch somebody lunge, right? What might we see at their foot or ankle that we might be able to correct to decrease stress on their Achilles?
Supination?
Yep. Would we see supination, too much supination, or not enough supination? What do you think?
Too much.
Okay. Anybody else?
Overpronating.
Okay, so we got both ends of the spectrum there.
Heel comes off the ground, and then we have pronation again.
Perfect. Okay. Yeah, nice. So if I'm going to, let's say I'll use this, right? So if I'm going to squat, here's my tibia, here's my foot, right? If I go into a squat and I don't have dorsiflexion, right? Then you're right, my heel is going to come in the air early. As soon as my heel comes in the air, what did I load all of a sudden? Right? My gastroc, my calf muscle, my tendon. So if I don't have dorsiflexion, then my foot's going to come into the air earlier, and I'm going to get higher loads on the calf. Think about someone running on their toes, right? If I'm running on my toes, my heel's not touching the ground, that's a lot more stress is on the posterior calf muscles. So great. So we may see a lack of dorsiflexion or early heel rise. The second one would be overpronation, right? Because remember, we want the calcaneus to invert. That would be supination. If the calcaneus is hanging out in eversion, the rear foot is in eversion, that would fit with pronation. That would change the vector of that tendon, right? If here's my calcaneus, here's the tendon running down the back of it, right? If it's used to being in this nice area, and all of a sudden my calcaneus is turned a certain way, now that tendon is being turned a certain way. So now instead of having a nice straight up and down fibers, you may see fibers that are a little bit more at a lateral angle. So the next person you guys see that has a really pronated feet, right? Take a look at them and see, is it coming from the midfoot? Where you know what, yeah, it's the midfoot that's touching the ground. Or is it the rear foot, where the rear foot's super everted and that Achilles tendon is no longer straight up and down, but it's more like at an angle, right? Imagine trying to keep pushing and pulling off of something that's not like this. Right? That's going to change the collagen fibers. That's going to make things more stressed, right? So good. So those are the kind of two big movement faults. The nice thing is we can correct both of those and see what happens. So if somebody squats, their heel comes up early and they have pain, I'm going to stick something under their heel. I'm going to stick something under their heel and have them recheck it to see if, hey, you know what, does that change your pain, right? Right. Just same thing with this foot pronation, right? I may have them do a squat, right? As we watch here, I may have them do a squat, watch them go into pronation, and then just retest it by keeping their foot in a nice supinated position. Hey, you know what, recheck it. What happens when you do that? I may stick the towel underneath it, right? Recheck it, right? What happens when you do that, right? So it's a way to check in the moment. And if they say, you know what, doesn't really change, it feels exactly the same. Okay, maybe I don't go down that route. They're like, oh man, that feels way better. I don't feel my Achilles pain anymore. Maybe I need to spend time looking at their midfoot pronation. Good, awesome. All right, so I think we've kind of examined enough of their ankle and foot, right? We've looked at mobility, we've looked at strength, we've looked at coordination, pretty much across the board. Hopefully we've looked at gastroc length at some point. Maybe we've looked at balance at some point, looking for anything. So now we're going to treat. All right, it is time to treat. What do you think we're going after? What would you guys treat? Patient with Achilles tendinopathy. Let's say they're acute. They've only had it for a week. So it's Achilles tendonitis. What would be our first interventions probably?
Modalities.
Modalities, awesome. What what are the modalities you'd want to use?
Ice.
Good. Okay. So cryotherapy. What else? What else?
E-stim.
Okay. E-stim.
Ultrasound, stretching, stabilization exercises, pulsed.
Okay. If we bring up, so as we know, there's lots of modalities, right? If we think evidence-based, right, our number one goal isn't necessarily just to make their pain better, right? It's actually to get rid of inflammation, which will then make their pain better, right? So can you think of something that will not just improve pain, right? So E-stim, we think of E-stim, not necessarily NMES Russian muscle activation, but just E-stim. That's really just a pain thing, right? You're just gauging out pain. So I'd say that might be a lot lower. So TENS, NMES, right? Those really aren't, research doesn't support those early on, right? Think about something that might help with inflammation. You may not use it as much.
Laser.
Good.
Iontophoresis.
There you go, boom, right? So the literature actually states that iontophoresis, which we can put medication into, right? That's what it is, as one of the best ones for early stages of tendonitis, is using iontophoresis. And then laser has been shown to be better than placebo, right? Ultrasound had benefits, but there was no difference than placebo. So whether you turn the machine on or you leave it off, the ultrasound, yes, it was helpful, but it was no different than not even having the machine on. So really there may be some placebo effects with ultrasound. So the two big ones were laser and ionto, and then ice, right? Ice, which they can do at home as well. So those would be the early stages of modalities, right? Great. So what else? Early acute rehab, tendonitis. You know, I just finished my marathon, my first marathon. I finished it 4 days ago, and my heel is just on fire, right? What else is going to be part of my rehab besides these modalities?
Light stretching.
I like the word light. All right, good job adding the word light. What else?
Functional rest.
Awesome, great job. Yeah, shut it down, right? Someone who has like tendonitis, it's inflammatory, right? That tendon is surrounded by chemicals, right? All these substance Ps, all these other interleukins, there's all these chemicals around it. The number one goal is get rid of those and then let this tendon heal, get back to normal. Last thing we want to do is make it work under this inflammatory state. So yeah, so rest is awesome, right? If you were a professional athlete, what do you think they'd do to you? Right? Probably put you on crutches and put you in a boot, right? They'd force you to not use it, right? That would be like, hey, we're going to get this to calm down as quick as possible, right? That might be a little extreme for the average person who has to go to work, have kids, this and that, to be non-weight bearing in the boot. So we may say, hey, you know what? No more running. Don't take the stairs. Try to limit your walking. Right? Try to be as off your feet as much as physically possible to let it calm down. Good.
Dr. LeMoine,
yeah.
I think you kind of just mentioned it, but like if you were to have a patient come in, would you brace them at any point? I know you kind of mentioned with the professional athlete, but what would you do?
Yeah, I wouldn't necessarily put them in a brace unless they had like a timeline to get back to. If they're like, hey, I got this, I've been training, I have a 10K in 2 weeks I'm going to run. Then I may say, hey, you know what? I'll put you in a brace, a little bit of a heel lift, and like just let the tendon come in, knowing that, hey, in 2 weeks you're going to go run, and we want you to be in as least amount of pain as possible. But I'd say if it's someone who is a recreational athlete and there's not a timeline, I probably wouldn't, because I'd rather them not lose any of their ankle mobility or lose any of their other things, and just it may take longer in the early stages, but it'll be better in the long-term stages. So good,
Awesome.
That's a good idea.
And then another question that just came in is, where would you fit in compression or taping to reduce the swelling?
Yeah, those can be those can be used for inflammatory as well, or for pain inhibition. So using like K-tape or some type of tent taping, leukotape, that can be used to improve pain. Studies show that this case series, not high level studies, but like you tape someone, they have less pain when they walk. So if it's someone who's walking around for work and even though they're limiting what they walk, yeah, you can put tape on them to help change maybe the angle of the tendon. But really what I think it does is I think it just loads the tendon in a new place, right? You think about Achilles tendonitis, it's not the whole entire tendon that is irritated. There's probably a portion of that tendon that's been overused. So if you maybe tape them and pull them into a new direction, right? So if I go to modalities, right, we kind of go into tent taping, right? If you pull that tendon into a new position, it just kind of, all it does is really reload the tendon to a different point. So I would say it's not a fix-all, but it's definitely helpful for just pain. Kind of like the patellar taping for patellofemoral, the McConnell taping for the patella, right? It allows you to just get away with more. So you're just loading it differently.
Is there research to suggest medial or lateral? Or is it just patient preference?
They say to go medial. So you make the lateral one longer to go medial, only because the calf tends to be, or the tendon tends to be with a everted heel, which is already lateral. So it's like, well, we're going to make it more, but I would say clinically, I do both. It's whatever one feels better. I try one, try the other. Compression can be great for swelling as well. Just realize if we tape it too tight, just the pressure may be painful. So it's kind of one of those ones where it's kind of tough. You want to wrap it tight for swelling and inflammation, but the compression on the tendon can be painful because they're very sensitive, right? Just like someone wearing a pair of shoes, just having the back of the shoe touch the tendon can become painful. So I'd say I probably don't do that as much because it's not really, it's more, the swelling tends to be more intra-tendon. So it's within the fascial sheath versus like in the ankle where it's more global in the fascia. It's not in the fascia as much as it's in the tendon sheath. So it's kind of already pinned in. So compression, not as much. I think one of the ones we were missing maybe is the heel lift, right? We talked about if someone lacks dorsiflexion, their heel goes in the air early, or if they go into too much dorsiflexion and it stretches it, those things are all painful. If you put someone in a heel lift for a short term, it allows them to walk with less pain, which is fantastic. Long term, do we really want them in a heel lift all the time? Now, what do they end up losing? If they're in a heel lift, what are they going to lose? Or what might be reduced?
Dorsiflexion.
Yeah, dorsiflexion, exactly. Good job. Which is one of the risk factors for this in the first place. But again, right now, the phase that we're in is just the, hey, let's calm it down. Calm down, calm down. Perfect. Okay, so let's move on from that. And we're out of this acute stage. Actually, no, I'm sorry, let me go back one. I think you guys talked about, someone threw out the word stretching, right? And the other one said like light stretching as well. So I'll just make a comment about that. Maybe 10 years ago, right? Anytime someone came in with a tendon problem, it was like the idea was, hey, we should stretch it. The reason why it hurts is because the muscle lacks flexibility. So it's pulling on the tendon a lot. So whether it's patellofemoral, whether it's lat epi, whether it's Achilles, the common treatment is stretching, right? Someone has patellar tendonitis, people were on their stomach doing like a prone quad stretch. Someone with Achilles tendonitis, they're up against the wall doing a calf stretch. Newer studies support the idea that actually when we have a tendonitis, it's a bunch of micro tears in that tendon that's been disrupted, and that's what makes it inflamed and painful. So if I have a bunch of little tears in it, I don't really want to stretch it because that can actually make it worse. Think if you have a cut on your skin and it's trying to scab over, trying to scar over, and you keep stretching the cut open, right? Now, clinically, people sometimes feel a little bit better with it in the moment, right? You get this release of endorphins, you're stretching, right? You kind of get this new sensation. So people feel better short term. But the studies have shown that actually the groups that have stretching in their rehab take longer to get back to return to sport than those that don't include stretching, right? So both groups are going to do strengthening. One group gets stretching as well. That group that got stretching didn't do as well as the group that didn't get stretching. So, so I would say if someone comes in with acute Achilles, and I'm going to put them up a wall and check their gastroc length or whatever, or put them prone, and they're really limited. They're limited in their calf muscle a lot. I'm going to probably want to stretch them or improve mobility. sorry, let me phrase it. I'm going to want to improve mobility there, but I may choose not to stretch it because I have to stretch the tendon, which is not what I want to do. So what would be another way to improve calf mobility without maybe having to stretch the actual tendon?
Joint mobilization.
Okay. So joint mob would improve dorsiflexion at the ankle, which is fantastic. How about if I'm trying to improve gastroc flexibility?
Soft tissue massage to the calf.
Yeah, exactly. Right. So either foam rolling or soft tissue. There's a study that looked at one group that got stretching, one group that got soft tissue, self foam rolling. Both of them had the same amount of improved dorsiflexion. Awesome. Right. So we can definitely say, hey, you know what? I'm going to work on calf mobility, calf flexibility, but I'm not going to sacrifice stretching the tendon. Right. Later on in rehab, we may actually have them do stretching, but we want to make sure they feel it in the right place. Right? I'm not going to have someone stretch their calf and have them feel it in the tendon and be like, hey, you know what? That's okay. We're stretching that tendon out. That's normal, right? The studies actually support if they feel it in the calf muscle, great, right? The tendon is being pulled on, no big deal. But if they feel it in the tendon itself, then we don't want to have them just keep going to town stretching that. So I like the word light because it may depend on where they feel it. But I also think that maybe we can work on it a different way with similar results without having the negative effects of pulling the tendon. Good. And that's a newer thought process, right? That's newer research. Okay, so that would be early. Let's move away from early rehab to more, let's say they're a tendinopathy, right? They've had this for, I don't know, 4 months. 4 months, they've kind of continued to run a little bit. Then they took 3-4 weeks off, got a little bit better. They went back to hiking, it came back. It's kind of something they feel, right? Doesn't limit them tons, but it's just been there and it's not going away, right? So we'd call that our tendinopathy, right? What are we going to do for rehab for that person?
Quad strength.
Quad strength. Okay.
Strengthening isometrics.
Okay. Strengthening isometrics of what?
Gastroc. Isometrics of the plantar flexors.
Good, good, good. Good. Yeah, exactly. Right. So, if we're thinking mid-substance, right? So remember that 55 to 65% of the time. So majority of the time people come in, it's going to be a mid-substance, not proximal, not distal ethicalcaneus, but in the middle of the tendon. All the research is supportive of using strengthening eccentrics, isometrics, concentrics around that area, right? To work on it. Now the idea is we want to dose them properly, right? That's the biggest thing is dosage enough to improve this long term, right? And so we'll talk about that. But remember, that is the gold. That is where we want to be. That's the long term. All this studies show this is what makes people better long term. It's kind of what fixes the issue long term. What are some of the other impairments besides calf strength? What are some of the other impairments that we might want to address?
Post-tib strength.
Okay.
Proximal hip muscles.
Good, right? And the nice thing is those two things, proximal hip muscles, post-tib strength, only if needed, right? If someone doesn't have a hip drop and someone doesn't have the leg diving in, maybe we don't need to work on glute med. If someone's arch doesn't collapse, maybe we don't need to work on post-tib. We check it, it's 5 out of 5, right? We don't need to spend time there. So, but those are definitely options to work on. Good job. Especially if we see them do that fault with their function. So the person that runs has pain when they're running, they have a huge hip drop on that side. Yeah, I may work on that. So good job.
Dr. LeMoine, a couple questions.
Yes.
Came in. First, do you know who wrote the study, I believe, for the stretching, kind of the new protocol for the Achilles?
It's in the guidelines. So
it's in the guidelines. Okay.
It's in the suture. So I'll go over it at the end. The mentoring minutes has it all, so I can figure out the exact one of that. Good. Was there another one?
And then I think these kind of play off of each other, but do you ever find that there's trigger points that might be contributing to issues in the Achilles? And then is there any research that suggests that dry needling of the Achilles is ever helpful?
The trigger points in the calf, yes. Clinically, if I instead of just soft tissuing the whole entire calf, which could take a while, it's like I'll find areas that are painful. So I may have them do like gentle contractions into my foot and look for areas that are hyperactive. So something that turns on first, there's common ones in the medial, distal calf, proximal, lateral calf that are two common ones that follow like these slings. If you ever take like a spatial sling class, there's ones that are more common. So I'll check those. And if they're exquisite tenderness there, then yes, I will work on the soft tissue to there. In California, we can't dry needles, so I don't do any dry needling in the clinic. I haven't really looked up any research on dry needling to the Achilles, so I can't necessarily answer that one. But good question. I mean, I would assume, right? I would assume dry needling would be helpful, right? Because you're kind of working on similar to the same idea of trigger point stuff. So yeah, good.
Awesome.
Good question. Okay. I would say the other one we want to talk about is dorsiflexion. So I know we talked about assessing dorsiflexion and all those joint mobs early, but still, if someone lacks dorsiflexion, you're mobbing the heck out of their ankle, you're getting their dorsiflexion back. If someone has a lot of pronation, we're working on that. Someone has the hip drop, so those are perfect. Right? And that's kind of what our manual therapy is all about, right? Can we improve dorsiflexion? Can we improve gastroc flexibility? Do we need to work on that subtalar joint, right? Is their foot not able to supinate? Is their rear foot not able to supinate? So we got to mobilize it, right? Let's not forget about those. If we go to TheraX, right? Coordination, this is kind of where we want to live at, is this eccentrics, right? So with our calf eccentrics. So in the video here, they're starting on a step. That would be considered like level 3 already, to be going off a step where you can go past neutral. Ideally, you want to just start flat on the ground. But if you think about grade of evidence, right? The studies from the guidelines say that when they gather all the studies and they look at it, that you can't really argue with the fact that eccentrics is kind of the ideal standard of where we want to be for treatment. With eccentrics, what do you guys think are some of the barriers to people doing eccentrics pretty consistently? Like if we know this is what works, we know eccentrics is helpful. What are some of the barriers to people getting better? Why do people have Achilles tendonitis then if it's so clear cut that people get better when they do these?
Late onset muscle soreness, balance.
Okay.
Lack of strength.
Okay. So those are all things we try to improve on, right? So the idea, we'll do our calf raises to improve on strength. Balance, right? If someone is doing heel raises for the idea of Achilles, I actually want to take balance out of it. So I'll have them hold on. I'll have them hold on as much as they can because I don't want it to be a balance issue right now. I just want them to be able to load the tendon properly. So if they have to use their hands to have better form, I'm all for that. But I'd say there's two things we're kind of looking for. I'd say, why do people continue to have Achilles problems? Why do people not necessarily maybe follow through with this exercise?
Lack of ankle stability.
Okay, possibly.
It's redundant, fatigue, safety reasons.
So the redundant one's an awesome answer, right? The studies show it takes 16 weeks to have really good outcomes, right? You're asking someone to invest a lot of time and energy and not really see a benefit right away, and to think about 4 months from now, you'll be better. If you just do this every day, in 4 months, you'll be back to running, right? That's kind of a lot to ask sometimes. So I'd like that. That's one. There's another one. So besides it taking a long time and doing the same thing over and over and over and over, right? There's another reason why people maybe don't follow through with this, or they don't get the beneficial outcomes that they would want.
Lack of endurance, set small goals, painful.
Yeah, painful. Exactly. The studies show that calf raises, when they do these eccentrics, or later on we'll talk about the concentric stuff, when they're doing tendon loading, it should be painful, right? If it's not painful, we're supposed to add weight to make it painful, right? That's the principle of loading the tendon, is to find what it can handle and then do a little bit more than that. And over time, the tendon adapts, the collagen adapts. So the studies show about a 4 to 5 out of 10 pain is what we're looking for. If they have too much, we can lower it down, take away less weight, give more support. If it's too high, if the pain's too low, then we can add weight to go up to it. Yeah, so that's perfect. So we think about, it takes a long time and it's painful. So if we look here, right? So this would be, so here they say if it's less than a 3, add weight. If it's greater than a 5, decrease weight. So we're looking for this 3 to 5 range of pain, right? And here was the parameters that the RCTs kind of came up with. So in week 1, you're doing 3 sets of 1 repetition, right? So they're really saying like, hey, you're still in this irritated inflammatory state. We don't want to overload the tendon where it goes into an inflammatory state, but we're getting ready to prep it. So week 1's pretty easy. You're doing 1 rep, 3 sets of it twice a day. So that's really only a total of 6 calf raises all day long. That's pretty much nothing, right? But as you see week 2, 3, 4, all the way up to week 12, you're starting to do more sets. Initially you add reps, and then when you go to a new set, you lower the reps. And then at weeks 9 through 12, your reps are lower because you've added more weight, right? So you've added weight to continue to get this painful response, right? So that would be kind of the idea for, again, there's lots of other protocols out there, but this is the main one from the guidelines that talks about this eccentric category. Good. All right. So if we go back one, all right. The last thing we'll talk about before I'm going to show you guys one thing in the mentoring minutes, which is like a little video that kind of pulls it all together, which I think is pretty cool with all the newer research. So heel lift we talked about, right? Sitting and sleeping, right? Those are 2 positions where we spend a lot of time where we may be in plantar flexion. So it's kind of important to make sure that if we're telling people, hey, we're going to work on your dorsiflexion, we're going to work on your calf strength, that they're not then spending 16 hours a day in plantar flexion, whether that's sleeping with their foot hanging down or sitting in a chair. So we want to make sure that, again, they kind of keep their ankle in as much dorsiflexion as able without feeling a stretch on the tendon, right? Or pain on the tendon. When we're stretching, we don't want it to hurt the tendon because we think of these little tears. But think about if we were to immobilize somebody, they get immobilized at 0 degrees, right? They get immobilized with their foot neutral. If that hurts, they put a heel lift under them to get them immobilized at 5 degrees of plantar flexion. So we want to tell people, just educate them that, hey, when you're sitting, try to have your heel underneath you a little bit more, slide your foot back. Right. So I'll play this. Right, so here she's in a lot of plantar flexion, right? Plantar flexion, that would be dorsiflexion, right? She's now in 5 degrees of dorsiflexion, right? We'd want her to hang out like that, and she's sitting, right? And then same thing for sleeping. Right. So here she's in a lot of plantar flexion, but we can then stick something at the edge of their bed to put them in dorsiflexion. People that sleep on their stomach, you stick something here. That's a lot of plantar flexion, right? All right, think about how short that tendon's going to get when it heals, scarring down. Stick something underneath them, allows them to put in a little bit of plantar flexion. Or you have them just scoot off the edge of the bed and their feet hang off, right? So little things like that can speed up recovery, right? We're always looking for, hey, this is the impairment we're going to treat, calf strength, mobility. But then you're like, well, what are little things we could do that are always helping us meet these goals faster, right? I'm sure patients would appreciate if we got better, if we got them better quicker as well. All right. So that would be kind of Achilles tendonitis or tendinopathy. I do want to show you guys this. Let me go to here real quick. I'm going to show you under PhysioU.com, under knowledge, right? I did a mentoring minute not too long ago, maybe like a year ago. And again, these mentoring minutes are when I pretty much do like a mini lit review. Now, I don't look at everything, obviously. I don't take time, but I pull up a bunch of different articles and I do like a 5 to 6 minute video on something. And so for this one, I did one on Achilles, and I think I used 1, 2, 3, 4, all right, 5, 6. So I looked at like 12 different articles and put together a video based on the articles. And we'll watch that. All of the main points about the articles are there. It has the table, right? So here's these dosages, 3 sets of 15, 2 times a day. Right? That's what they're doing for these reloading. And then 3 sets of 15, 2 times a day. They do it regular heel off of they do it with on a flat surface, and they do it off of a step. So you have these protocols that if you want to look up and use, they have your pain scale. Again, that 2 to 5 or 3 to 5 is what we're looking for. Right? And then you have the main conclusions of all these different articles. And in there is where you'll find one that talks about the stretching component not as helpful. Right here, let's watch this video real quick. Will you guys let me know if you can hear it, Cam and Chris?
Cannot hear it.
No.
Can I hear it? If I take off the headphones.
Yes.
You can hear it now?
Great stuff. Really.
Yeah? Okay.
Hey guys, welcome to today's Mentoring Minute with PhysioU. I'm Marshall. I'm here with Jonathan. Today, the Mentoring Minute is Achilles Tendonitis. We talked about Achilles problems. Great stuff. There's really 3 areas. You have the insertional, you have mid-substance or mid-tendon, and you have muscular-tendon junction. Out of the 3 least common is the muscular-tendon junction. If there's an injury there or pain there, really the best thing to do is just rest, mobilize, let it come down, most likely related to the inflammatory process, and you progressively reload the tissue. The most common one is the mid-substance. About 55 to 60% of all Achilles would be mid-substance problems. We'll spend most of the time there. And then lastly, you have your insertional, which tends to be one of the most painful and most chronic ones. Doesn't get better nearly as well as mid-substance. It doesn't respond well to resistive exercises like eccentrics and concentrics. Most of the time, it's due to improper use. So when they talk about Achilles injuries, they say, is it overuse? You have to kind of load it up, or is it misuse and you have to change mechanics? So we talk mostly about mid-substance, right? Between 2 and 6 centimeters up from the insertion. Research shows that the best way to rehab these are loading. The majority of the research talks about eccentrics, and we'll go through those in a second. But it talks about starting with sets of 10 to 15, 3 sets, no extra weight, and really going up with 2, down with 1, slow, controlled motion. Adding, as things get better, you start to add weight, and as you add the load, you start to add resistance and speed as well. So for eccentrics, right, in the starting phases, you want to go up on the non-involved side. So most people jog with weight on the left, go up both legs. You want to make sure they get high enough to calcaneal inversion. Make sure the weight bearing on the first leg. Lift this leg up and slowly lower it. 3, 2, 1, down. And this one down. Up with mostly the left. This one in the air. Down. So research, most of the studies talk about a 3-second way down. Slow, it's controlled. They go up. You want to go as high as they can to see that calcaneal inversion. Time under tension. 3, 2, again, we're looking for 15 repetitions, 3 sets. In the early phases, when there's no extra weight, you're doing them twice a day, as long as paid, say under a 5 during the activity, and the next day, say under a 5. That's considered the exception. More than a 5, they took a day off. They did it. If it still was a 5, they dropped down once a day. To progress from level ground, it's now adding a step. Okay, up with 2, most of the weight on the uninvolved. Lift it up in the air, slowly lower it. Again, nice and slow, going past neutral and more dorsiflexion. So again, longer, lengthening on. Again, now once you add the step, they only went to 1 time a day instead of 2 times a day, but still 7 days a week. Third progression would then be now adding weight, adding loads to this eccentric exercise. A lot of patients, they put on backpacks, or kettlebells, and you want to hold enough weight where you're still getting loading on this technique. It still has to be painful. So again, you still go up with 2, most of the weight on the left, lift this in the air, slowly go down, go down. Now, once you start getting into the loaded phase of resistance, so adding lots of weight, they only went to 3 times a week. They said it takes about 72 hours. It can take up to 72 hours for that tissue to kind of get back to normal after doing heavy resistant loads.
So I'm going to pause that for a second. So again, the key thing there is early on, it's twice a day when you're just doing body weight. When you add a step, they went to 1 time a day. When you added weight, they went to 2 to 3 times a week. So as the load and difficulty went up, the amount of times a day and a week went down.
multiple other RCTs. Not only did they do knee straight eccentrics, like we've been practicing, but they also did knee bend. They had to bend both knees. They can go up with two, most of the weight on the uninvolved, lift the foot in the air, and slowly lower. Same protocol, 15 reps, 3 sets, just to get it with knee straight, knee extended, and knee bend. The later phases of rehab, they went through the loading, they started to work on speed. So they had to do quick hopping, but not really linear, just hopping through the heel. So up, 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 knee straight, up, quick. Had to do it. So you're still working on contractions, but now you're working on the speed of it. So you're getting your loading, the tendon. The goal of the eccentrics is to improve organization of the collagen while decreasing the thickness and neovascularization. That helps with pain and return to support. A couple of cool articles talked about when it's time to get back to running. They compared ground reaction forces in treadmill running versus over ground running. Now, a lot higher ground reaction forces in treadmill. So you want to encourage maybe starting outside on the track first with running. And one of the biggest things we want to educate about is the vertical displacement. There's a study that shows that the higher vertical displacement, the more load up. Trying to avoid jumping while they run. Lastly, we switch to insertional. So again, the one that is lower down.
I'm going to pause it there, recap. So, right, we're reloading the tendon, getting them stronger with these calf raises, eccentrics, concentrics. Eventually, those people are going to go back to sport, right? One of the common issues is, hey, you know what? I'm pain-free with walking. I'm pain-free with all my exercises now. Great. Those are all been, 3 seconds per repetition, everything under control. And now you're going to go back to running. That's a big jump to load that tendon. Maybe they have the strength, but has that tendon gone through the speed, right? Remember, tendon is an overuse, whether it's a load of number of reps, a speed issue. So the goal is in those last couple of weeks, you now want to start adding in speed variables. So that would be the fast repetitions where you're doing these boundings, right, later on, or even getting back to running. The study talked about treadmill versus ground. So starting outside versus on a treadmill has lower loads and then progress to a treadmill for higher loads. So think about just like someone with an ACL tear, right? You want to train them for their sport so they don't end up back in your clinic, right, a month later saying their Achilles hurts again.
Right. Tends to be more painful, doesn't respond well to eccentric exercises. What they found is that working on more midfoot control.
So this one's talking more about insertional pain, where you're working more mechanics of the foot, forefoot, rear foot, stuff like that.
Maybe angle, the friction. Teach them to get better control, or get better versus overwork. Should include dorsiflexion and good outcomes with insertional tendonitis. What was interesting is they found that really stretching the calf muscle, stretching the tendon, is not helpful to a lot of these Achilles tendons, especially with mid-insertion. We talk about there's micro tears in this tendon. It's not strong enough, it's kind of too loose, and so when we stretch it, we're actually making it a little worse. So something to think about when we have these patients. Lastly, they did this study, this RCT that looked at eccentrics versus concentrics. Most of the eccentrics, which is tons of stuff out there, is compared to modalities. The eccentrics are way better than ultrasound and laser, so eccentrics is kind of the gold standard. This RCT looked at concentrics versus eccentrics. But they found that both of them actually reorganize the collagen the same. Concentrics and seems both decrease neurovascularization, improve tendon, decrease tendon thickness. So really, eccentrics and concentrics are both good. The difference was eccentrics had a better outcome as far as patient compliance and patient satisfaction. So we have here, go ahead and stand on this leg open. Go up 3 seconds. 1, 2, 3. Down 3 seconds. 1, 2.
Perfect. That's kind of the last of that. Yeah, so the last one just said that a newer study says concentrics had the same outcome as the eccentrics, meaning as long as you go slow, you hold it, you really don't need to do just eccentrics only, but as long as you do the concentric up with 3 and then down with 3, patients who are willing to do that more. So, and you think about it in the clinic and you've tried to describe or explain to do eccentric with somebody, how many times do you feel like you have to go through it? No, go up with this one, down with this one. No. Up with this. And then, so you feel like sometimes patients cannot know what they're doing at home, so then they just don't do anything, right? Patients are fearful of doing it wrong, so instead they do nothing. So this way you can be like, you know what, don't even worry about it, up, yeah. Just be aware though that there may be more pain with it because of the concentric phase, and you might have to do eccentrics. Yeah, that's all I have for Achilles tendinopathy, probably more than you wanted to know. I think that video is a nice 6-minute summary of probably everything I said in the first hour. So, yeah.
Yeah, I just want to say follow us on Instagram and YouTube because Chris and I control the social media, and we posted that video about 2-3 weeks ago, and it got a lot of views. But imagine if you would have watched that before Dr. LeMoine asked all these really hard questions at the beginning. May have been a little beneficial. So follow us on Instagram, and we'll be sure to check out your profile and follow you back.
Thanks. Let's see. Were there any questions that?
Yeah, we got a good question that came in. Is this protocol also for post-surgical repair of Achilles?
No, not for post-surgical repair. That's very, very different than that. That has a definitely an angle component to it, where once you start your calf strengthening, you start at 0 degrees, like just isometrics into a wall. And then you progress to more dorsiflexion, which stretches the tendon. Yeah, very, very different. So I don't, maybe in the later phases where they work on the number of reps and then the speed, but early on, no. Cool. Let me just share this screen here. Boom. Okay. So again, you guys should be getting an email in a couple of days that has the recording. I recorded it, has a recording to it, has the link to the mentoring minutes as well as the pattern we played out today. And then I'll be here again next Friday, 9 a.m. And we're doing another, we're trying to spend 3 weeks on each joint. So we did 3 for the knee. The next 2 are going to be around the ankle. And then, yeah, moving on. Cool. Thank you guys. Thank you, Cameron. Thank you, Chris. Thank you, everybody that was there, everybody that's participated. Again, shoot me an email if you guys do need proof of attendance, as some of you have kind of asked for, and we are working on it. I know it's been a couple weeks, but we are getting that together. So thank you guys. Thank you. Thanks, Cameron. Thanks, Chris.
Thank you very much.
No worries, Eric. My pleasure, man.
See you guys.
Let's see. Do you guys want to just stay on, Chris?
Yeah.
Or do you
have to invite Cameron back?
Cameron dropped out. Let me at least stop the recording.